A 55-year-old man is hospitalized following a deep vein thrombosis. He is given heparin and warfarin to help prevent further thromboses. Heparin is discontinued soon after. The patient soon develops blackened areas on various areas of his skin. Which of the following best describes the cause of this reaction? Choice A, rebound synthesis of coagulation factors from cessation of heparin. Choice B, deficiency of antithrombin 3. Choice C, persistence of undegraded clotting factors. Choice D, presence of mutated clotting factor. Or choice E, vitamin K deficiency. I'll wait 5 seconds and answer the question. This patient is experiencing warfarin-induced skin necrosis, which occurs as a result of transient hypercoagulable state after you give warfarin. This occurs because when warfarin is first given, even though it's inhibiting the synthesis of vitamin K related factors, such as coagulation factors 2, 7, 9, and 10, it also inhibits protein C and S. However, out of these, protein C has the shortest half-life. So there's going to be a period when you first give warfarin where protein C is all going to get degraded through its half-life, whereas the coagulation factors are still going to stay around. So you have a hypercoagulable state, which manifests as this warfarin-induced skin necrosis, which tends to happen most in fat-rich areas of the body, such as the breasts and the buttocks. Sometimes to prevent this from happening, we give heparin at the same time as warfarin, which is what happened in this. But for whatever reason, heparin was discontinued, maybe because they just discontinued it too soon. But if you do that, obviously you didn't use heparin for long enough, and the same thing can still happen, and you still get warfarin-induced skin necrosis. So as mentioned, it's because of the degradation of protein C and the absence of degradation of clotting factors early on in warfarin therapy. So choice C, persistence of undegraded clotting factors, is the correct answer. Taking a look at some of the other wrong answer choices here. Choice A, rebound synthesis of coagulation factors from cessation of heparin. This is actually a nonsense answer choice in some ways because heparin's function does not include inhibiting the synthesis of clotting factors. It doesn't work that way. What heparin does is that it works through activating antithrombin 3, which inhibits coagulation factors. So it has nothing to do directly with the synthesis of coagulation factors. But trap answer choices have shown up like this before, probably just to test students and see if they understand how heparin actually works. Choice B, deficiency of antithrombin 3. Antithrombin 3 deficiency would lead to a resistance to heparin because, as I just mentioned, heparin works by activating antithrombin 3. So, what would happen in these patients is that you would give them heparin and they would probably not have an increased bleeding time or a prolonged PTT. Obviously, that just doesn't really fit this vignette at all, so it's the wrong answer. Choice D, presence of mutated clotting factor. This can refer to a number of things, but most likely it is referring to factor V laden, which is the most common inherited cause of hypercoagulability. A mutated factor V is unable to be cleaved by protein C. So obviously that means that factor V is going to stay around and it will lead to hypercoagulability. And it usually presents in questions as a relatively young person, probably in their 20s or 30s, getting recurrent DVTs. Choice E, vitamin K deficiency. A patient with vitamin K deficiency would already have difficulty synthesizing clotting factors, so they would already have an elevated PT/PTT. I mean, essentially, what warfarin does is very similar to a vitamin K deficiency, right? Because warfarin inhibits the synthesis of vitamin K related factors. So, in the setting of someone with vitamin K deficiency, if you gave them warfarin, I guess what it would really do is just make them way worse. And technically, people with vitamin K deficiency can still get warfarin-induced skin necrosis, but regardless, that's not really related to what is being described primarily in this question, right? So it's just not a good answer choice. So bring it back, you really want to understand what heparin and warfarin do, and you want to understand warfarin skin necrosis. It really goes back to your basic understanding of the clotting cascade and knowing where warfarin and heparin slot in that. Again, remember that warfarin works by inhibiting vitamin K related coagulation factors like 279 and 10, as well as protein C and S, whereas heparin works through antithrombin 3 to exert its effects. I hope you found this video helpful. I'll see you in the next one.